and colleagues to Home Nursing Foundation CME webinar series. Today, our topic is on swallowing difficulties in the community, and we are very, very pleased to have with us Ai Wei to be sharing on this topic, and Dr. Ng Wai Chong will also be following up with a case study. Home Nursing Foundation is the largest home healthcare charity in Singapore, providing home-based medical, nursing, therapy, and home personal care services to more than 5,000 frail and vulnerable patients each year. We also run 2 senior care centers with rehab at Hougang and Buangkok, as well as active aging centers in these areas. We want to serve the needs of both the dependent and well seniors in the community and aim to improve their function, health, and well-being. Under the prolific leadership of Dr. Ng, this series of continuing professional education was started to raise our understanding and standards of practice of holistic and person-centered care to all our patients and support their caregivers, empowering them to live very joyfully in the community. Over the years, we have covered a wide variety of topics, very interesting and relevant to community-aged care, such as end-of-life care, functional rehab, dementia, falls and osteoporosis, mental health, Parkinson's, wound management, caregiver support, social prescribing, and many other interesting topics, which I encourage you to scan the QR code so that you can watch the videos of past series in YouTube. This afternoon, we are very happily looking forward to the topic that Ai Wei will be sharing with us. So without further ado, I will pass this time over to her.
A very good afternoon to everyone. Welcome to today's webinar series. We'll be touching on community speech therapy approach to swallowing difficulties. So this will be the outline of what we will be covering. So basically, I will touch on who are the patients that we see, what do we do. We'll also touch a little on the IDDSI, which everyone should be quite familiar with now, followed by can we wean off the entity, yeah, and as well as what to say during informational counselling, and when do we refer to the speech therapist in the community setup, followed by a case presentation by Dr. Ng, and then we'll close with Q&A, right? So typically, who gets referred to the speech therapist? These are the typical patients that we will receive. We will get referral from AIC. So patients with a newly inserted NGT from recent admission to hospital, or patients on long-term NGT wishing to start oral trials, or patients who have had their diet or fluids downgraded due to recent illness or admission to the hospital. We also see patients who are undergoing transitional feeding plan to wean off the NGT, as well as patients who are already in the community, already at home, but having increasing difficulty to feed orally or oral refusal. So in other words, we actually see, we can group these patients into these 3 categories of temporary or transient dysphagia, meaning that they were actually okay, but because of a recent episode of medical condition, they were admitted to hospital, then they present with swallowing difficulties. But then having had the medical condition resolved and they are discharged back home, the dysphagia may also resolve on its own. So this is what we will classify as temporary or transient dysphagia. We also have another group of chronic dysphagia. These will be patients whereby they have had old strokes, okay? And because of that, there is a long-standing swallowing difficulty. We also have another group of progressive dysphagia, meaning to say most likely we'll see in patients with dementia, Alzheimer's, and Parkinson's disease. So as time goes by, we will see that caregivers, NOKs will will voice concerns that it's getting more difficult to feed, that the patients are eating lesser. Okay. So basically, what do we do? Of course, first and foremost, we will have to gather information. Where can we get the information from? Will be from hospital discharge summary or doctor's memo. And then at the point of visit, we will get more information of how the patient has been eating, what are the eating and drinking patterns pre-morbid, that means prior to the onset of the swallowing difficulty. Okay, having gathered all the information, then we will proceed with feeding the patient with, so depending on how they present, so we could start with a level 0 thin fluids. We could also start with thickened fluids, depending on how they present on the day of assessment. Then we'll take note of the swallowing presentation. We will also take note of the patient's motivation or willingness to take orally, as well as caregiver support. Having done the assessment, then we will be able to decide whether, yes, should we do oral or non-oral? So should we feed or should we not feed? Okay, or is it a case whereby we can start transitional feeding or continue with the transitional feeding with the aim to, so there are three phrases here: transitional feeding versus pleasure feeding versus comfort feeding. So transitional feeding will refer to more like, yes, with the aim to wean off the feeding tube, that there is a chance to wean off the feeding tube. Pleasure feeding will be, we probably have tried some small amount of oral feeding, but yet not enough to actually sustain the patient's nutrition or hydration. So they may be doing both. So NGT as main source of nutrition, but yet still allow oral feeding for pleasure. Versus comfort feeding, whereby this will refer to patients that wishes not to have the feeding tube and wish to continue with the oral feeding for as long as they are able to, as much as they can tolerate. Then we'll also look at swallowing rehab, whether is this patient suitable for swallowing rehab, meaning to say swallowing exercises, or the patient needs more of a diet and fluids modification, meaning to say that we change the diet or we change the fluids so that they can still eat and drink safely. Okay, so of course, currently, most of the patients that we receive, the referrals that we receive, they will have had either a FEES, a fiber optic endoscopic examination for swallowing, or a VFS, a video fluoroscopy for swallowing, done in the hospital. This is very useful information for the community SD, so that we are able to know, oh, okay, when they were in the hospital, these tests were done. So it's an objective swallowing assessment, so that then we are able to understand better the patient's swallowing presentation and whether what are the risks involved, how high is the aspiration risk. So in pictorial form, you'll see this one is FEES. Okay, so we don't usually do it within the patient setting, not in the community. Some private ENTs, they do, okay, with private SD in the comfort of the patient's home. But yeah, not for HNF, not currently, and not for other service providers that I'm aware of currently. So usually we'll still rely on these objective assessments to be done in the hospital setting. So this is how the FEES looks like, okay? And this is how the swallow X-ray VFS looks like, okay? For the next few slides, I'll be sharing some videos of VFS so that we can understand better what is it that we are looking out for when we actually assess a patient's swallowing. So this is VFS on for a normal swallow. So it's a moving X-ray. This is a lateral view. So this is the jawline. Okay, the tongue is here, the lips, the teeth. Okay, that's the whole larynx here. The airway is here. Food channel is here. Okay, so this is a normal swallow. I will play the video. So the patient is chewing on the bolus, the blackened part, that's the bolus. So it's a nice, clean swallow. Nothing is left behind in the mouth. Nothing is left behind in the throat, and nothing went into the airway. We'll just watch that again. So chew, 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 and then trigger swallow, push back, everything nicely going into the esophagus. Okay, so nothing gets left behind, nothing went into the airway. So that's a normal swallow. So that's what we will see on a VFS. So moving on to the next slide is aspiration before swallow. So as you can see here, there is the feeding tube is here, the NGT is here. Okay, so aspiration before swallow means that the food that we fed this patient, it actually went into the airway before the patient actually swallowed. So we will watch that. So this is probably, yeah, quite a solid piece of food. Definitely not puree diet. So definitely not your level 4. Probably maybe level 7 easy chew. So but not very good oral control. So the food here is going into the airway. He hasn't swallowed, now he swallows. And he coughs. Okay, so he choked on it, basically. Okay, we'll just watch that again. Okay, so that piece of food. So by right, we should have everything all in a nice bolus, in a cohesive bolus, but this one is speed up. So the tongue control is not great. So the food goes back all the way, goes into, and then, yeah. So this patient is not a silent aspirator because he responded to the food entering the airway, therefore resulting in an attempt to actually cough it out. So these are the reasons why some patients we said no solid food, yeah, because this may be what is happening or may happen, okay, if they are on solid food. So we will look at another one of aspiration during swallow. So this is when at the point of swallow, the food or the fluids actually enter the airway. So we'll have a look at it. So this most likely level 0 thin fluids, most likely. Okay, so it fills up all the piriform sinus, and at the point of swallow, you can see the trace here. He aspirated on that much. Okay, so bear in mind, it also depends on how big the bolus size is. So doesn't mean that when someone aspirates, 100% of it will enter the airway. Yeah, so again, that is why that's the beauty of having a swallow X-ray done while they are in the hospital, so that we understand better. We are able to weigh what are the risks involved. Okay, so let's watch that one again. So it fills up all as a delayed trigger, and at the point, yeah. Okay, so the squeeze wasn't fantastic, that it was right up to the piriform sinus when we actually triggered the swallow. That's where then the fluids actually went into the airway. So this is when thickened fluids may be helpful to reduce the aspiration risk. Okay, and the next one is aspiration after swallow. So this is when the food actually enters the airway after the swallow. Okay, so we'll have a look at that. So it fills up, fills up, fills up. The squeeze is poor here, that's why it's all stuck here at the piriform sinuses. Then it overflows because it has nowhere else to go. So with repeated swallows, it just goes into the airway. We'll watch that again. So he's trying hard, push everything down, but it's all stuck here. So for these kind of cases is when you feed a patient and you don't see anything else left inside the mouth, but for all you know, it's actually still left in the pharynx. Okay, so that is why then speech therapists always remind caregivers, helpers to make sure they really did swallow before they give the next room. So because this may be what is happening inside that we are unable to see at bedside. Right. So the next two videos will be on FEES, the fiber optic endoscopic examination for swallowing. This one has audio, so we'll just
Not necessarily abnormal to have small amounts of residual food material located in the vallecula and base of tongue.
so we get some anatomy. Yeah. So this is a top-down view. Okay, so for the scope, it hangs at so it goes in through the nose, and then we have a top-down view. So we can't see for feces, we can't see what is going on inside the mouth. We can't see how they're preparing the food in the mouth. Okay, so this is the base of tongue. This is your epiglottis. Okay, so this is a valleculae, this space here. The space here is your piriform sinuses. Okay, inside here, this is your airway. These ones are your vocal cords. Okay, so the wash, this is a normal swallow. So the food is dyed green so that we are able to track where it is traveling.
Regions.
Okay, we'll watch that again.
Not necessarily abnormal to have small amounts of residual food material located in the vallecula.
Point of swallow. So when we swallow, it wipes out. The reason being is that at the point of swallow, we actually stop breathing. The whole airway, the vocal cords will close, everything will shut down so that then the food can travel safely through the UES, the upper esophageal sphincter, and directly into the esophagus. Okay, so that is this is B. So this is a normal swallow. The next video will
Not
be
necessarily abnormal to is defined as solid or liquid food entering the hypopharynx for greater than 1 second before a swallow is initiated, and often suggests neurological problems as the etiology of the impaired swallow.
breathing. Time this can go in, and then now he swallows. So this is when the patient has got a delayed swallow trigger. So when the speech therapist say, oh, patient has delayed swallow trigger, then now in your head you can picture, oh, okay, this could be what is happening. So the fluids just flow in, flow in, still breathing. Any time is at risk of overflowing into the airway. Okay, so it could fill up to the valleculae before they swallow, or it could fill up to the piriform sinuses before then the patient trigger a swallow. Yeah, so this is so it's what happens when we say, oh, delayed swallow trigger. This could be what is happening. That is why then sometimes thickened fluids is actually advised to slow down the flow so that then it will go nicely with the swallow trigger. Right, so that's all the videos that I have for today. The next section that we will go to is what is IDDSI. I think we should all be quite familiar with it. So it refers to an International Dysphagia Diet Standardization Initiative. Currently, over more than 30 countries have actually endorsed and adopted this framework. For us in Singapore, it's under the EatSafe SG. It's coming to about a year since we went online. With this EatSafe. So all institutions, so now no longer are we using the old terminologies. All discharge summaries, all reports will come with the IDDSI terminologies. However, disability homes, because I cover disability homes as well, they have yet to reach out to disability homes. I'm not so sure about special needs school, but they are getting there. Okay, so we should all be quite familiar with this already, but just a quick refresh. Okay, because we're all set for the compulsory EatSafe lectures, I think about 2 years ago. Okay, so basically this is the IDDSI chart. Okay, so it goes from level 0 to level 7. So the lower numbers are 0 to 4 refers to fluids, okay? And from 3, 4, 5, 6, 7 refers to the types of food, okay? So, so level 0 is thin fluids, meaning nothing is added to the fluids, is it as is. Then we have level 1, slightly thick, level 2, mildly thick, level 3, moderately thick, level 4, extremely thick. So previously, it used to be mildly thick is nectar, moderately thick was honey thick, and extremely thick was pudding thick. Okay, so they have also included like liquidized diet. So food can also be liquidized. So which is why they share the same labeling. But then it's just that, so the patient could be on level 3 liquidized diet and then on a level 2 mildly thick fluid sometimes, but not so frequent. Okay, this combination, but it is a possibility. Okay, or on a puree diet, and so usually it kind of goes hand in hand. If let's say it's for puree diet, then yeah, patient may be able to either tolerate a level 3 fluids or a level 4 fluids. Okay. You also have your transitional foods here. Transitional food refers to food that will change its texture when it's added with saliva. So things like wafer, ice cream, your Cheetos. Okay. Yeah, so those are transitional foods. Basically, they are used for in preparation for chewing training. Okay. So the next one will be, yeah, it's just to further description of what the different levels are. So your mince and moist, the food particles should not be bigger than 4 millimeters. So it's basically like the size of the space between your fork, the prongs. Okay. And a soft and bite size should be about 15 mm by 15 mm. Okay. Whereas easy to chew, there is no specific size that you need to adhere to. Okay, so it's more of the mince and moist and the soft and bite size. Okay. Yeah. So, like I was saying earlier, so for the mince and moist level 5, it has to be about 4 mm. Okay, that's for adult. Okay, for child is half of that is 2 mm. For level 6, soft and bite size is about 15 mm. Okay, so these are how you will test the different levels, the different food texture. So for puree, it needs to have some form. Liquidized, they will just flow right through. Okay, puree, you still need to have some form. Okay, mince and moist, okay, so it's like that. And soft bite size, when you actually press in, it will flatten and it won't bounce back up. Okay. But basically this food test and flow test is more for audit purposes. Yeah, but I just want to highlight that so with the flow test for the level 0 to level 4, so as you can see, there is a range. Okay, so it's not like a specific, you must have it like this, it must flow that. So even for level 2, you have a range that, if let's say after that 10 seconds, the liquid remaining falls within here to here, it's accepted as a level 2. Okay. So that's all for IDDSI. And so next thing is, can we wean off the NGT? So when can we wean off? What is required for us to be able to wean off the NGT? So there are many factors, as you can see from the slide here. So it's never only one, it's a combination of all these factors in order for the NGT to be weaned off successfully. So first and foremost is really the patient's willingness and awareness to eat and drink. Okay, and this will tie in very closely with their alertness level. Okay, secretion management. This is one huge factor usually, especially for patients who have been eating okay, then had chest infection or had COVID, then lots of secretions, went into hospital, poor secretion management, NGT inserted, then come back, secretion still like this, then still requiring about 3-4 suctions a day. Yeah, and then that we don't know when the secretion is going to resolve. That is one difficult thing to manage in terms of secretions. Yeah. So next one is committed caregiver. So if you have all these, but you don't have a committed caregiver, things won't go as well. Okay. And a supportive understanding caregiver, okay, or family, because if the caregiver is a helper, then the helper also needs to support the understanding of the patient's family members. Okay, so everyone needs to be on the same page. Everyone needs to understand what is going on, what is the process like. Also financial support in terms of obtaining thickener, in terms of getting ready-made puree food. So financial support is, of course, very important as well. And last but not least, a supportive medical team. So the whole team needs to come together in order for the NGT to be successfully weaned off. So any part that is not in tune, then it reduces the chances of us being able to wean off the NGT. Okay. Next one. So having said that everything is all in place, everything is in an ideal situation, then we will aim for to start off with a 50 ml, 100 ml fluid or supplement. We usually start off slow, of course slow, usually sometimes maybe 30 ml. So depending on how, but we will aim for at least a 50 before we can, oh, okay, maybe we have a chance. Okay, so and we usually will start off with fluids and supplement because that is what they are already taking. So we don't want to put on extra pressure on the digestive system in the initial phase. Okay, so if let's say they are able to achieve 50 ml, 100 ml of fluid or supplement at one go, then we can start to push for replacement of one NGT feeding with oral feeding. So basically one supplement, one can of Ensure or Glucina is about 250. Now we have got Presubin and Diton. So sometimes it's lesser, but sometimes it takes about 180. Yeah, so it's quite feasible. If let's say the patient's stamina for oral feeding is there, then it's quite easy to actually replace. So once we're able to replace, so typically a patient on NGT feeding will have about 4 to 5 feeds, 4 to 6, yeah, depending again on what the dietitian's prescription was when they are in the hospital. So once our one replacement of one NGT feeding with oral feeding is successful, then we can push to having 2 meals being replaced and then subsequently 3 to 4 meals. And lastly, then we have to ensure that they are also able to take medicine orally. Sometimes we forget, okay, or help caregivers like, oh, can eat already. Then they forgot, oh, okay, how about the medicine? Then you see the patient doesn't want to take medicine orally. That's another challenge, another obstacle that we will need to counter. Okay, so if all goes well, that's when then we are able to wean off the NGT. So, of course, at every point of the recovery process of the therapy of our visits, it's very important of what we say, how we say to the caregivers, to the patient themselves. Okay, because they don't know what they don't know, right? So we sometimes are in a better position to, okay, this is what it is. So it's very important that we provide those choices without instilling fear and guilt. Okay, it's probably their first time, right? They only have one set of parents. It's their first time encountering such situation whereby, oh, should I feed? Should I not feed? Okay, so whatever we tell them, just need to bear in mind that it's not to instill fear, it's not to instill guilt. Okay, and we need to carry on and take the time to explain If they choose this, then what are the potential consequences? If you choose this one, then what are the potential consequences? Because they won't know. Yeah, we're in a better position because we have had experience. We know, okay, this goes, what are the possible scenarios? If you choose like this, then what are the possible scenarios? With family members, most of the time, they do not know, they're not aware. And they also don't know what to ask you because they don't know. Yeah, so it's important that if we have the knowledge, then we let them know so that they are better able to make the decision. Okay, it's also important to let them know of the disease progression, especially for dementia, for Parkinson's cases, right? And the importance of accepting what the things that we cannot change. Okay, so that is that. So basically, this slide just tells everyone that, yeah, so these are the people for any allied health professionals, for anyone actually, this will be our circle. Yeah, okay, we have interactions with the patients, with the NOT, with the helpers, with physio, with the dietitian, with the nurses. So at any one point, we have to be accountable for all these people who are connected, okay, with the care of the patient that we are seeing. Okay, and so last slide already. So when do we refer to the speech therapist? So in the community, yeah. So again, I have divided it into those patients with temporary or transient dysphagia, those who are like not currently on NGT but wants to go back to oral. Okay, so if let's say the acute medical condition have resolved, okay, there's a good chance. Improvements in alertness level, improvement in secretion management, all these tick, 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 yes. Okay, then yes, go ahead, refer to the SG. Okay, or those who are on oral, but then due to UTI or current chest infection, they are not eating well, they don't want to eat, eating lesser, urine output is less, considering NGT or diet modification. Okay, so this kind maybe send to A&E first to treat the medical condition. You get the ST in, we are not able to help solve the problem, the underlying problem. Okay, so we need to understand that dysphagia doesn't stand on its own. There's always an underlying cause to it. It doesn't stand on its own. It's not like, oh, you have a swelling problem. No, it's swelling problem due to a particular medical condition. Okay, so whether is there a need to downgrade, okay, or a need to supplement, then yes, then you can refer to us, then we can step in. But if there is a medical condition that it needs to be treated, then don't ask us in. And so it's not considered as urgent ST because we can't help with the UTI, we can't help with the chest infection. Okay, for those on chronic dysphagia, meaning those that have it's on long-term NGT, okay, for as you will be able to see later in the case presentation, okay, for a few years on NGT. Then now they feel, oh, maybe can try oral. Okay, again, if there's improvement alertness level, improvement secretion management, they're more willing, they're more aware now, then yes, why not? Go ahead and try. Okay, or those who have been on level 4 puree diet, level 3 thickened fluids, and then have been eating well, now decide, how about more normal food? How about level 5? How about level 6? Yes, then yes, refer to the ST. Okay, progressive dysphagia, okay, those who, so for your patients with dementia, okay, they're on NGT, then families say, hey, so poor thing, maybe can eat something or not. Yeah, so then again, depending on the medical condition, if it's on Parkinson's, we need to see whether it's safe or not. Okay, so your Parkinson's, you need to make sure whether is it okay. You have to weigh the risk. Okay, safe for pleasure feeding, okay, or comfort feeding. Okay, for dementia, okay, change of behavior. So like patients with dementia, sometimes they have a period whereby they don't want to eat. But then after that, they are okay to eat. So in that sense, then yes, if they are willing to eat, then yes, get us in. Then we check, hey, still can. Okay, then eat. Yeah, so these are the cases. Or those are oral, but then as the dementia progresses, it's getting more difficult. They're only taking maybe a few spoons a day. Okay, then that's where then we come in, not to make them eat more because we are We don't have magic fingers. We can't go in and say, oh, because SG come now, can eat more. We are not able to do so. Okay, so we're only able to then do more information counseling. So if you go this way, then what will happen? If you go this way, then what will happen? So that's where then our role will change slightly. So it's not so much of safe to eat, not safe to eat, eat, should not eat. Yeah. Okay. So with that, and I will pass it to Dr. Ng for the case presentation.
Thank you, Ai Wei. Yeah, I was reminded by Christina that we forgot to introduce you. So let me just have a brief introduction. Ai Wei is one of the very rare speech therapists that does home visit, and she's our speech therapist in Home Nursing Foundation, but she's also the co-founder and partner of her own company called Speech Therapy Works LLP. Over 20 years of experience as a speech therapist in Singapore, and she began her career in SGH. So those who have worked in SGH might have known her. And so currently, apart from HNF, she also works, as you heard from her, in disability home and nursing home settings. So she does locum for the various places as well. So that's Ai Wei for you. So now I will do a case discussion. Using that case, I have 5 questions for Ai Wei, and then we will open up the discussion. Many of you have Q&A. By the way, I think In Keng requested Ai Wei to turn up your volume of your speech. We can hear you, but it's a bit, we need to strain a little bit, but to me, it's still audible. Yeah, thanks In Keng for raising this up. So let me, maybe Ai Wei can stop share, then I will share my screen. So this is a case, not my own patient, but it's a patient of HNF, seeing another home medical doctor and our nurse. So it's a 57-year-old lady. Years ago, I would think that, oh, this is a middle-aged lady, but now this time I'm thinking, hey, I'm about that age myself. So this lady had meningoencephalitis and had dysphagia. So I share with you the history. She was admitted to HNF under the home nursing service in November 18 for NG tube change. And February 2019, not 29, was referred to our home medical service. When she was referred, she was 57 years old. Her background was hypertension, hyperlipidemia, impaired glucose tolerance. There was a schwannoma in the left foot that's actually quite immaterial. And then there's a lipoma in the breast, umbilical herniatomy. But this was significant. Spinal stenosis with surgical procedure, T8 to T10 decompression laminectomy with no instrumentation. So there was a spinal stenosis. I read from the doctor's note that she was also quite obese. In March 2018, there was a leak from the dural membrane, right, at the spinal cord area, and causing a pseudomenicoceal. And then they had to, what has to be admitted to the hospital and had another decompressive laminectomy at T11, and with the repair of the CSF leak. However, unfortunately, there was a complication of acute meningoencephalitis and venous sinus thrombosis, cavernous sinus, which is in the skull, just below the brain, with multiple brain abscess. And because of this severe encephalitis, meningitis, and thrombosis and brain abscess, she was started on NG tube. When the doctors, the notes I got it from, I combined from the doctor's first notes and also the nurse's first notes. So the medication at that time was atenolol, baclofen, bisoconazole, and then lactulose, multivitamin, senna, eye drop, and white soft paraffin. So very minimalistic. So that's actually quite nice. The functional status, she was really quite poor in terms of functional status. Bed bound, trolley bath, but will be transferred to the toilet twice a week because she's very heavy. You need 2 persons. And she did some kind of stationary cycling once a week, but you need 2 persons to help. MBI was 3. So this is really, really poor function. AMT was 1. Braden scale was 10. There were there were sacral ulcers. She was non-communicative. In terms of systems review, there was some pain at the waist. Otherwise, the mood assessment was mentioned to be fair. Okay. And then about the social setup, because you heard Ai saying that the rehab potential, a lot of it depends on caregivers. She lives with a spouse and 3 children. The husband was the main caregiver and very caring and speaking up for her and very concerned, right? And there was a maid trained when she was admitted to the hospital in March, and then by the team from CareLink. And at the home, there was a hospital bed, and there was a pressure mattress, and there was exercise cycle, commode chair, wheelchair, no grab bars, ramp to the toilet. So obviously the discharge was very well managed, very well planned. Probably the committee, I understand this was a hospital in the north, so there was a very good H2H team, CHT team that managed the transition back home. Okay, so so this was so that was the situation. That was 2019, right? And there was many visits by our doctors and nurses, so I didn't have time to read everything. I just show you the latest, which is on the 6th of May when our doctor visited her. How was she like? Huh? There was no admission since July 2021. The last admission was catheter-acquired UTI. It's very common for people on IDC. So that was 4 years ago, nearly 4 years ago. She was no longer an NGT. The waist pain was very seldom. There's no need for any painkiller anymore. No constipation, BO once every 2 to 3 days. Sleep was maintained, mood was fair, oral feeds was maintained, full share 3 meals, can even eat chicken rice, durian, biscuit, there was no choking. Functional status did not improve a lot. She was still largely bed-bound with trolley bath and toilet bath once a week using commode, and stopped the stationary cycling. There was TCM massage once every 2 months, and there was they have recently stopped PT by the helper, but I saw the doctor's note that the family hoped to have our home PT visiting to start some kind of physiotherapy. Then in between, from 2019 to 2025, she received multiple swallowing rehab by Ai, okay? Intermittently. So July 2019, and because of the funding, you can only continue for a few months. So the initial notes was rehab potential was fair, started on laryngeal stimulation. Then subsequently, she was discharged 5 to 6 months after the period of rehab, was only for pleasure feeding. So from what Ai was sharing, we know pleasure feeding is just for the pleasure of it. It's not enough to maintain the nutrition. And then September 2020, 1 year later, the family did not give up, referred again. So Ai went in again, and then also for a short period of 6 months. And then January 2022, again, was referred, trying to wean off NG tube, but still not successful. But January 2024, referred again, and it was successful. So with this case, I have a few questions for Ai, okay? How did you assess the potential to wean the person off NG tube when she was uncommunicative and had an AMT of 0? You mentioned that it's about alertness and secretion. She did not have secretion. There's a very supportive family. Alertness, she was probably alert, but non-communicative. So I wonder how you assessed rehab potential. So what swallowing exercises did you prescribe? There was some mention about laryngeal stimulation. So what do you usually do? So perhaps the audience, I can see today we have nearly 400. It's quite a lot of people in the ground. And then when I was going through the names, many new participants to our webinar. You're all welcome, and we're very happy to have many people participating. So I'm sure there's a lot of interest to learn how to help our seniors remove off the NG tube, because all of us know how painful it is to insert NG tube and so much suffering for somebody who cannot enjoy food. What did you teach the caregivers about food consistency? So when you wean the person, did you jump straight to level 7, or what did you do? And then, so at which point did you decide that this person can be completely weaned off NG tube? And how can doctors and nurses help to facilitate your role as a speech therapist? So I will stop share so that all of us can see Ai when she speaks.
Right. Thank you for the questions, Dr. Ng. This was a great case to be brought up for today's webinar. So referring to the first question, how did I actually assess whether how do we wean off? So basically, when I first went in, that was 2018, 2019, patient was really not really responsive. Her eyes were not really focused. Sometimes yes, sometimes no, fleeting. So she wasn't opening her mouth. Her neck was stiff. So we started off with so from there on, so the patient alertness part, yes, she's alert, but she wasn't actually aware. She wasn't really aware that, oh, okay, I want to eat, I want to drink. So the awareness was not there.
Yeah.
Asked her to open her mouth, she wasn't. So she was basically very tight. So she was so we had to work through with the neck muscles. We had to work through with her mouth muscles and all. So which wasn't easy because she wasn't following instructions.
Yeah.
Yeah. So because of that, then gradually so really depended on the helper at that time to actually carry out the neck stretches and the massages to the face to make her less tight. So over time, yes, we managed to put in a small teaspoon to heat some water, droplets of water. So I did start off with just level 0 for her, but very tiny droplets. Then the thing is that the main difficulty we had was that she was just holding it in the mouth.
Yeah.
So she wasn't swallowing. So again, over time, then okay, so we were just practicing just small droplets of water, which we couldn't really progress much, which is why then at the end of that 6 months, then yeah, so then the family carried on with the exercises that they are able to do with her. So yeah, so in terms of exercises, we could only do what we can do outside. She wasn't participating. Yeah, so we tried to do cold spoon. We tried to do stimulation at the back. Not easy because she wasn't opening her mouth.
Oh,
Yeah.
so sorry, Ai Wei. So if a person who is not able to open her mouth, you mentioned about face massage, neck stretching. How do you do that?
We usually will apply pressure, gentle massage, but sometimes it works, sometimes it doesn't. But that's the only thing we can do. So we will
The temporomandibular joint or
TMJ joint. Yeah.
Okay,
So
TM
then
joint.
circular movement and all the way down to try and relax
the jaw because they're clenching. Yeah. So we relax the jaw. Then the neck stretching, what do you do?
So
Is it
the typical neck stretches, as well as because her larynx was actually very stiff as well. So gentle laryngeal massage.
so move the larynx side to side, move the face from side to side. Okay.
Yeah. Okay. So then I think then with the second referral, because then the family never gave up. I mean the husband never gave up. So then they asked me to go in again. So this time round, she was more responsive. I think her eyes could track.
Yeah.
And she will smile. And she sometimes can actually nod slightly with So then and mouth can open already. So then we proceeded with trying out level 2 fluids for testing.
Yeah.
But with level 2 fluids, so we tried again. She holds it.
Yeah.
So the helper continue on with the practice on level 2 fluids to get. So the main aim was to get her swallows to be more consistent, that she responds more.
Yeah.
But again, not easy. So we kind of like was there status quo for quite a while, and then yeah. So then moved on. I think with the third referral, they're saying that okay now she's again more. So then I went in, then I tried her on level 0. She's actually now she's able to actually she holds it for lesser time. I mean, we don't know what happened within all this period. We don't know if the exercises is the one that help or it's a natural improvement or overall improvement.
Yes.
So we tried her on level 0 fluid, small teaspoon, and she was swallowing. Yeah. We
That's
tried
the third time.
plain
Third time will be 2022. 2022 will be it will be like 3 years
Yeah.
since the encephalitis. It's something very interesting because most of us thought about neurological recovery 6 months to 1 year. Beyond that, we consider that as plateauing. But this case shows it's after 3 years, Sorry, I cut you. I just wanted to raise an important point.
Yes,
Yeah,
yes.
thanks. I will please.
I'm also very amazed with how much she has improved in that sense.
Yes.
Yeah.
Yeah.
So then so when we tried on plain water, there was also a difference between plain water and on syrup.
Yeah.
or on flavored beverage. So on plain water, she will hold longer and she has a tendency to actually cough and choke on it. But when we serve flavored beverage on level 0, she's actually she will swallow faster. Her response is faster. But when we thicken up the plain water, then she holds for even longer. Again, the use of the thickener in this case was not really to her benefit. It may be safer,
Yeah.
but then it didn't trigger the swallow.
Maybe it's not palatable.
Correct. So which brings us to which is why we have to be flexible.
Yeah.
It's not that safety, yes, we need to be safe, but we also need to then explore as well and to weigh the risk. Yeah.
Yes.
So sometimes you say, plain water, they don't swallow, we put thicker.
I
But so
tasted thickened
scented.
water. It's horrible.
It's horrible. There's a taste and
Yeah.
it's just horrible. It's like eating starch or glue.
Eating gum.
Yeah. Tasteless gum
Yeah.
with a bit of weird, like, yeah.
Yeah.
Mm.
Yeah. Potato starch.
So,
Very
Yeah.
person-centered, I think, this
Yeah.
approach. Yeah.
yes, correct. So then we started off with then the helpers changed along the way. So with this case, the helper played quite a major role because although the spouse is actually involved, committed, but then most of the caregiving was provided by the helper.
Yes.
The helper, whether the helper does or doesn't do it is, So then we started off, so we said, okay, go try yogurt, try mashed potato, try puree food. So they will say, okay. Then the next time I visit, they say, don't have the food. Nobody buy.
Oh.
Okay, so nobody buy. So what is it that you have? Sometimes we have yogurt, sometimes don't have. Sometimes have, sometimes don't have. Sometimes buy, sometimes don't buy. So it is
Yeah.
So, even though we want to push, like, okay, can eat already, but because of the limitation, therefore we couldn't go as fast as
So there's social factors, limiting our rehab. Yes.
Correct. So that is why that again drag for very long. We've got food to eat, no food to eat.
Okay.
So not that they don't care, it's because he's still working.
Yes.
Spouse is still working. So
Yes.
So family dynamics wise, and children have their own expectations and mindset as well. So once they tell the helper can go ahead, the other one say no, don't give.
Yeah.
If here one cough cannot give anymore, stop. Then stop until the next time I come. Then we're back to square one. Which is why for this case it was a bit longer.
Okay.
So because of these social factors,
Yes.
So then what else? So then eventually then with the last referral in
2024.
Then now I think there was another helper change or something like that. There's some change again in the family dynamics. So now got food to eat already. Now every day we'll have food.
Yes.
That the food that can cater. So initially was just soft food, so porridge,
Yes.
soft kind of food, which the helper was able to prepare. And the helper diligently will serve when we'll give.
Yeah.
That's where then things started. So the consistency was there.
So a lot of effort from the family is very important.
Yes, correct. So anyone it is not doing, then yeah. So we just have to step back and pace with them. We cannot say that, oh, you must like that.
Yeah.
You want, then you must like this. It sometimes cannot. It's not.
I can imagine there are many of our colleagues here in this audience, they work in nursing homes, So it must be really difficult for them to win because there's a lot of work, a lot of patience involved. Yeah.
Correct.
Yeah.
A lot of things need to be in place.
So maybe the last question I have was, I mean, you've worked with a lot of doctors and nurses.
Yeah.
Surely there are those who are very collaborative, very helpful, very supportive, but surely there are also some, maybe out of ignorance or perhaps out of certain disillusionment or something, they don't collaborate so well with you. So what would you like to say to doctors and nurses with regards to swallowing rehabilitation? How can we collaborate with the speech therapist?
Oh, I think first and foremost is really take the time to understand that particular patient that we are seeing together.
Yeah.
Understand whether the dysphagia is a temporary one, it's a chronic one, or is a progressive one. Before then they start to think, oh, okay, can the ST do anything?
Yeah.
So because they see the patients more regularly in that sense.
Yes.
The ST is not in the picture. They do the 3 monthly reviews.
Yes.
So then they're able to pick up, oh, okay, this kind, okay, can or cannot, maybe.
I notice, I mean, I do cover, from my past experience as well, a lot of time hospital discharge a patient on NG tube. And then, of course, when you first take them on, there are a lot of issues we have to settle. Then after a while, we did not think about weaning off NG tube because we just assume that as necessary and we carry on. So I suppose if one of the things I hear from you today is if the person is alert enough, family is supportive, and this patient is motivated, and the secretion is managed, we should always consider referring to ST, right?
Yes.
Because hospital acute phase, I mean, yeah, she may not be acute. And even for this lady, the encephalitis, obviously all of us would think it's permanent, but then there is recovery there's neuro recovery as well. So that was a very interesting lesson today for me. Yeah. There are 9 questions from the floor, but I'd like to steal one more question from you. You mentioned comfort feeding. For me, especially in home care, we are doing palliative care, whether they are near end of life or not, it's all palliative care, focus on quality of life. So comfort feeding is meaningful in itself. So if say a person doesn't want NG tube, only want comfort feeding, eat as much as they can. If they cannot eat enough, they don't care. How would you advise? What is the way to feed so that it is relatively lower risk?
Okay. So again, of course, then we have to make sure that the nutrition is there, right? Nutrition.
Sometimes comfort feeding, you may not have optimal nutrition, but it's for comfort. Yeah.
Whatever that they can feed in.
Yeah.
Matter.
Yeah.
So usually, then we will go to use the supplement.
Okay.
Use that supplement instead of go and cook porridge. You're so hard, and then they should eat 2-3 spoons. Yeah.
Okay.
So then we will from my experience, then it is yes, we do the comfort feeding. We try feeding just the supplement. So if the supplement ensure, be it ensure, Presobin, Diben, whichever one that so that they feed small amounts but regular time.
Then
but also at the same time is that they may also offer things like their favorite stuff like
durians.
Yeah. So basically it comes back to the medical condition. If it's a dementia case, it's because don't want to eat. But then
let's say dementia, don't want to eat,
but then will eat some things that they like.
鸡虫饭, no? A lot of senior like 鸡虫饭. And then durians, of course, everybody loves durians. Yeah.
Or coffee and things. Then by all means, I would say try.
Yes. So is there like a position of the head? I used to hear that you have to like a smell of the morning rose or something, that kind of, is there a way to swallow that reduces aspiration?
Of course, typically textbook-wise is of course we sit up sit up.
Uh-huh.
That is textbook lah.
Yeah.
At home, sometimes they don't even have a hospital bed. They are being
Yeah.
propped up by pillows and
Yeah.
folded and whatnot.
Okay.
So basically, at least a 60
60 degrees.
yeah, and to ensure that the head is not hyperextended.
Okay.
Also, they're not being fed like that. Yeah. So
Thank you. Yeah.
yeah, otherwise, it should be okay.
So
in terms of-
I hear it's not so important, this position. Yeah, but of course, as upright as possible.
upright as
Yeah.
possible. But of course, again, comfort is another thing that we need to consider. Yeah,
Yeah.
and duration of the feeding in that position will also need to take note of.
Thank you. Thanks, we need to go to the questions from the floor. Otherwise, it cannot be just my questions. Okay, there are a few questions related to food consistency. So there's one about transitional feeding. What kind of food texture do you start with? Maybe we can cover this question together with the second one. In IDDSI language, can we serve level 5? Level 5 is finely means, right? Diet texture after modification done, like cream cracker plus Milo plus thickener. What are your thoughts? This is about transitional feeding and recommended texture.
Okay, so again, it depends on the cause of the dysphagia.
Yeah.
So it depends on the cause.
Yeah.
Let's say if usually we will start with puree diet as the safest level 4 puree
Yeah.
diet to transition. So
Okay,
usually,
level 4.
so it will be liquids first.
Yes.
Whether we need the thickener or not. If let's say can do already with whether the supplementation that means with the ensure or the glucina, if they're able to manage that, then we can move on to a level 4 puree diet.
Oh, let's say the cause is due to multiple infarct. So it's a dysphagia, neurological dysphagia. So do you still start with fluid level 0, level 1, or do you go straight away to 3 or 4 in puree diet?
Again, it depends on whether the oral phase, how is the oral phase.
Oh.
So basically, when we do get a CVA case, that patient, right, will have actually gone through a rehab stage already. But
Yes.
the time it comes to us is when they already do whatever that they can do.
Okay.
So
Yes.
all the active rehab that is possible, everything all should have already, if this is a CVA case, stroke case, they were already done and encountered and already sorted out. Then by the time they reach home, it is to see whether how else can we progress. It's like, oh, okay, now here we are, we have to, So it will be based on whatever the speech therapist memo from the hospital. Then I will then know, okay, then I will then start maybe with a level 2, or I can start with a level 0.
Okay.
Yeah.
Thank you. The next question is quite specific. It's about patients with delay swallow trigger, that they tend to have this feeling to clear their throat. And if they, maybe I'll just read the whole question. With delayed swallow trigger, do some patients feel the urge to clear their throat? One question. Or if they start clearing their throat with poor saliva control, do you think they'll start having to keep clearing their throat without coughing? And any advice or education for caregivers when they get very worried when the patients keep clearing their throat?
Okay, so again, clearing throat. Clearing throat, sometimes then we have to really make sure whether even at rest, are they clearing their throat? If at rest they're clearing their throat, then it's unlikely it's due to the food. So these are patients whereby chronic smokers.
Okay.
So it perpetually is then it's probably they are having
phlegm,
which is
it's chronic smoker,
chronic smoker kind of So again, it depends on why the throat clearing happens.
Yeah, it may not be dysphagia. It could be GERD. It could be COPD. Yeah.
So unless it specifically happens after every spoon that they yes, then it's likely that there is still food. So it's probably unlikely to be a delayed trigger, but probably weak swallows, therefore left residue inside the throat.
Okay. Thank you.
It's not cleared after the swallow. So they still feel there's something there that they need to actually clear it to swallow down again.
I see. Oops, sorry. I think it's my phone is connected to my laptop. Sorry. So the question, that means the answer to the question is really depends on the cause of that persistent clearing of throat. It may not be swallowing related.
It may not be swallowing related.
Thanks. There's another question related to transitional feeding. People on NG tube, does that get in the way of transitional feeding because there's a tube at the throat? Would they it's very unnatural. I mean, what do you think?
Yeah. So again, research-wise, they have shown that the presence of the tube in most population doesn't actually obstruct the flow of the bolus. So in specific cases, if they have osteophytes or they have really very narrow pharynx, then yes, then the NGT is obstructing. But typical population, it should not actually affect the bolus flow.
Okay, thank you. The next question is about persons with ID, intellectual disorder, disability, or cognitive disorder who progressively refuse eating and drinking and are averse to NG tube. How would you approach? I suppose if it's a case without dysphagia, is somebody just having that reducing urge to swallow or maybe forgetting to swallow and so on. So yeah, how would you approach such a case?
I think then this one will probably need some time to actually talk with the caregivers.
Yeah.
So whether what is it that they want, are they comfortable to just let them eat whatever that they want to eat? So sometimes they can just go with just one meal, or sometimes that day they don't eat. Then the next day they eat. So it really depends. But again, the important thing is to really bring forth to the family that this is not because he cannot eat, cannot swallow, it's because don't want.
Yeah.
So in order that you don't want, then you can only offer, I mean, we cannot offer the whole list of food for that particular day as well.
Yeah.
So, but if you know that he may have a tendency to eat this particular food, then by all means serve. I have a patient who eats the same thing every day. He won't eat any other stuff. And he will only drink Yakult.
I also have patients like that.
So, but then how? But if that is the way that they are able, then I wouldn't stop.
Yeah, especially with ID and cognitive impairment. Yeah, so really it becomes a case of ACP, PPC, philosophy, what's the person's values and what is important. That kind of discussion already, right? It's not, it's not about dysphagia. There is a few other questions which were covered partially, but since there are still a lot of people in the audience, let's discuss again. It's about time period. What is the time frame for patients who are on temporary dysphagia? How long does temporary dysphagia last?
I would love to be able to answer that. I get questioned myself whenever I go in to see how long will this last? How long? It's the same. How long will the secretion last? No one can tell.
Yeah, correct. It's like the case I presented. Took us 4 to 5 years.
Correct.
I mean, for most of us, after 1 year, we would have given up already, but the family did not give up. And then in the end, it was successful, and she was quite young, and now she can enjoy herself and can eat durians. And my friend Sirana is in the audience. I agree, comfort feeding should include durians. And nowadays, I got this patient in the nursing home, and I asked her, you want to eat durian? She said yes. I feel I have to buy it for her next week when I go and visit. There's another case. There's a question about head flexion. You've answered it just now, but there's still this question. Head flexion useful to improve aspiration. Is it right? Flexing the neck. Yeah. Does it help in preventing aspiration?
Oh, wait. Flexing forward, flexing backwards.
Flexing forward. Yeah.
Okay. Well, basically, I think it's probably the participant is referring to probably a chin tuck position.
Yes.
Basically, right, actually, because our airway is in front, our channel is behind, and because we share a common path before the stage, right? So if you do a chin tuck, you're kind of like protecting the airway.
Oh,
So closing a bit more and then opening more of the, so yeah, you kind of like added protection for the airway. So yes, in a way, chin tuck, yes. But if you have someone who drools, who can keep, then you cannot do that. Then all the food will just come out.
oh yeah.
And yeah.
Yes, yes.
So again, it depends.
Yes.
But yes, generally we will call for, yes, if the head is tucked in slightly, it will increase the airway protection.
Thank you. So the last question we also partially touch on tight jaw muscles as part of dystonia or post-brain injury. Can we consider clonazepam, baclofen? These are all antispasmodic medicines. Yeah, what do you think? Would you request for the doctor to prescribe something like benzodiazepines or, to reduce the spasms?
And if let's say the family is agreeable to try,
yeah,
then I don't see why not. Yeah.
Otherwise, you can do the massage, as you say, TM joint and then down the jaw.
Massage, we don't know. We don't know when it will then actually release it also.
Yeah. Okay. I think that's all for the questions. Someone added a question just 1 minute ago. Does swallow deteriorate with normal aging? Do you know?
Yes. So in a way, yes, it does. Because as we age, our taste buds change.
Yes.
Our taste buds will change. We have less saliva. Then the dentures cannot speak on so well. So yes, over time it may it may worsen, but it won't worsen to the point whereby you're unable
to swallow. Yeah, I suppose it's also similar to sarcopenia. As we age, our muscles get weaker. Yeah.
At risk of
Yes.
But again, it's just not one problem. It's it's multiple factors.
Yes, thank you so much. It was a very interesting discussion, and I've learned so much from you. Thank you very much.
Thank you.
Christina?
Thank you very much, Aiwei, for not just the knowledge, but really inspiring us also and encouraging us and answering a lot of the questions that we had to improve the care of patients so that they can really live a higher quality of life, and brings a lot of meaning and joy also to the family members, not to just write off a patient, even though they may have been having progressive dysphagia. So thank you very much, everyone, for joining us this afternoon, and we look forward to the next month's program, and we hope to see all of you again. Thank you, everyone.
Thank you.
Bye-bye. Thanks, Aiwei.
Next month,
presentation.
Next month, we're having Zalia again to touch on insomnia in older adults as well as people with dementia. So it'll be quite interesting as well.
Yes, a lot of conditions that we are seeing more and more, but yet we don't know what are all the options available that is outside of just medications and the
we can't just keep doping people, right? Okay. Okay, bye-bye.
Thank you. Thanks, Aiwei. Thanks, everyone. Bye-bye. Have a very good weekend ahead.
Have a good 端午节. Grateful that we can all eat dumplings.
And hope you get to do your Aikido.
Yeah. Okay.
Bye.